This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Hello, and welcome back. Now that we've gone over some of the basic anatomy of the human brain, I'd like to turn your attention to the field of neuropsychology. In this lecture, we'll define neuropsychology and introduce the categories of functional abilities that neuropsychologists assess. So, what is neuropsychology? The term refers to both an experimental field and a clinical field within psychology that aim to understand how brain functioning influences behavior and cognition. Neuropsychology is also concerned with the assessment, diagnosis, and treatment of various brain disorders. Experimental neuropsychologists help to further our knowledge about different brain disorders by performing experiments related to functional deficits and by publishing their findings in peer-reviewed journals. I actually consider myself to be an experimental neuropsychologist. These individuals primarily work in research settings at universities or research hospitals and will typically have a doctorate degree in experimental psychology. By contrast, clinical neuropsychologists work directly with patients in a hospital or private practice setting and specialize in the assessment, diagnosis, treatment, and rehabilitation of people who have brain disorders. In many cases, a primary care physician or even a neurologist will refer a patient to a clinical neuropsychologist. Clinical neuropsychologists have a doctorate degree in clinical psychology with a specialization in neuropsychology. Both experimental and clinical neuropsychologists assess functional abilities related to memory, language, attention and executive function, visuospatial abilities, sensation and perception, motor skills, and mood and orientation. We'll discuss all of these categories throughout this course as we examine specific brain disorders that can affect them. But for now, let's go over the basics of each one, starting with memory. It's important to remember that memory is not one single thing. There are different types of memory. In people with brain disorders, some types of memory may be impaired while other types may be spared. This is because different types of memory are associated with different areas of the brain. Very often, people assume that memory loss is just a normal part of growing older. They'll say things like, "Yeah, Grandma has trouble remembering what she had for breakfast, but she can talk for hours about her younger days, so I know she must be fine." But the fact is, she might not be fine. Our memory for things that are happening in the moment, or that just happened, is a different function from our memory for things that happened years ago. One memory system can be functioning okay, while the other might not be. And even the one that appears to be functioning okay may not be functioning as well as we think. I mean, sure, maybe Grandma can talk about her youth in great detail, but can she talk about things that happened 5 years ago? How about 2 days ago? Typically, when people start to lose their long-term memories due to a brain disorder, the loss follows a temporal pattern. They tend to lose the most recent memories first, and then other memories start to fade in a backward temporal sequence. Friends, caregivers, and family members may not notice this pattern or simply pass it off as something that happens with old age. After all, Grandma can still complete daily activities like getting herself dressed in the morning, cooking her favorite meals, gardening, and so on. Well, memory for these types of things is yet another type of memory, and one that tends to stay intact in the majority of people with brain disorders. As you can see, When we talk about a person's memory, it isn't one thing we're talking about. A person can be perfectly fine with certain types of memory, yet have difficulties with other types. Knowing what types of memory are affected and assessing the severity of the memory loss can give us clues as to what might be causing the problems. So let's go ahead and discuss some of the categories of memory that are most affected by brain disorders, starting with what's known as working memory. Working memory helps us hold on to a piece of information temporarily in order to complete a task. This information typically disappears once a task has been completed. This type of memory is highly attention dependent, meaning it dissipates rapidly with distraction. For example, let's say you're interested in ordering a pizza, so you ask someone to give you the phone number for the pizza place in town. You might recite this number to yourself as you reach for your phone to make the call. If someone interrupts you while you are repeating this number to yourself, the number will be gone. You're using your working memory in order to hold this information and then use it by dialing the phone to order the pizza. Or suppose you go to the grocery store and place 6 items in your basket. If you look at the price of each item and add up all the prices in your head to get a sense of what your total bill will be, you're using your working memory. We also use working memory in conversations when we need to remember what the other person said in order to appropriately respond to them. Working memory is primarily controlled by the frontal lobes, specifically by the prefrontal cortex. Another type of memory is long-term memory. This consists of information that's held indefinitely in the brain. There are various subtypes of long-term memory, including episodic, semantic, and procedural. Episodic memories are memories for specific events that occurred at specific times. Examples might include your first date, your wedding, the birth of a child, the death of a loved one, and so on. Semantic memories comprise the knowledge we have about factual information independent of where or how we learned that information. For example, you can probably tell me what a stove is, but you probably don't remember how you learned it. Semantic memory, in other words, is what we often call general knowledge. Both episodic and semantic memories are often called declarative. They're memories for facts and events that can be consciously recalled. The hippocampus, a structure in the limbic system, plays a key role in the formation of these long-term memories. Many scientists believe that each long-term memory we have is actually a stable and permanent neural connection that's been formed and is widely distributed throughout the brain. Here's an example. Let's say you get married. You probably have a lot of memories from that day. Things that you've visually seen, like the bride's dress, the cake, the decorations and gifts. Things that you've heard, like the conversations and the music. Things you've tasted, like food and champagne. Things that you've smelled, like food, cologne, or perfume. And things you've touched, like someone you danced with or a child you held. Recall from our previous lecture that each of these senses activates a different area of the brain. Vision activates the primary visual cortex. Hearing, the primary auditory cortex. Taste, the primary gustatory cortex. Smell, the primary olfactory cortex. And touch, the primary somatosensory cortex. So the memory of your wedding is not stored within a single brain area. Instead, it is the result of links between neurons that connect to each of the brain areas just mentioned, creating a neural circuit that corresponds to all memories of that particular event. So you have an intricate, widely distributed neural circuit that is specifically associated with your wedding. If memories associated with any of your senses are activated, for example, maybe you see someone who attended your wedding, or you hear a song that was played at your wedding, or you taste food that reminds you of your wedding, the entire neural circuit of your wedding will be activated and memories will pop up into your conscious awareness. Procedural memory refers to the skills we learn and demonstrate through performance. We often tap into these kinds of memories without consciously thinking about it. Knowing how to do things like ride a bike, use a pencil, and take a shower falls under the category of procedural memory. Simply put, they're things you just know how to do. Procedural memories are controlled by the basal ganglia system in the brain and are usually not affected by brain disorders. Okay, we just covered a lot of information about memory. Think you can remember all of it? The next category we are going to discuss is language. Language consists of a number of different components. One of these components, known as receptive language, refers to a person's ability to understand simple spoken language. Another, expressive language, refers to a person's ability to repeat back words or phrases that are spoken to them, name pictures shown to them, and produce words on command. Additional components of language include things like the ability to read, write, and spell. Deficits in any of these areas are related to different diagnoses. We will discuss the relationship between language deficits and specific brain disorders throughout this course. Next is attention and executive function. Attention is generally divided into at least two categories: sustained attention and selective attention. Sustained attention refers to the ability to pay attention to something over a prolonged period of time, whereas selective attention refers to the ability to focus on certain things while filtering out anything extraneous or distracting. Executive function consists of 4 different stages: volition, planning, purposeful action, and effective performance. Volition is the capacity to formulate a goal or intention. Planning involves identifying and organizing the steps needed to carry out the goal or intention. Purposeful action means putting the plan into action, so initiating, maintaining, switching, and stopping sequences of complex behavior in an orderly and integrated way. And effective performance refers to whether the person can monitor, self-correct, and regulate as necessary to complete the goal or intention. Imagine the following scenario. You have friends coming over for dinner at 6 p.m., but your daughter comes home from school around 3 p.m. and tells you that she has an art project due tomorrow. Because you don't have the items needed to complete the project at home, you make a list. It turns out that all the items you need are not at the same store. So you plan out an efficient travel route to get from one store to the next. You also can't be distracted from looking at other items that you don't need or chatting with friends who you might run into because you are on a tight time schedule. This scenario requires you to 1, identify your goal, so volition. Buy all of the items you need in the time window that you have. 2, organize the steps needed to carry out your goal, so planning. Make a list and a travel route. 3, put the plan into action, so purposeful action. Get all items on the list without getting distracted. Maybe even come up with alternative routes if there's an accident or traffic. And 4, complete the goal in the time allotted. So effective performance. Get all of the supplies in a successful manner before 6 p.m. Both attention and executive function are primarily controlled by the frontal lobes, specifically the prefrontal cortex. As I mentioned earlier, working memory also falls under the category of executive function, as does something called perseveration. Individuals with frontal lobe damage tend to perseverate. They get stuck in set. Perseveration is the consistent repetition of a word, phrase, or gesture despite the stopping of the stimulus that led to the word, phrase, or gesture. And it is common in people who have sustained damage to their frontal lobes. For example, you and I might have a conversation about asparagus. Then we exhaust that topic and move on to talk about the weather. A person experiencing perseveration, however, would manage to keep bringing up the topic of asparagus during the weather discussion. Now on to the next category, visuospatial abilities. These abilities reflect our capacity to identify visual and spatial relationships among objects. This includes things like knowing where objects are in space, understanding and identifying the similarities and differences between objects, estimating the distance between two objects, navigating through space, and accurately reaching for objects, to name just a few. Individuals with visuospatial deficits might do things like bump into objects or inaccurately perceive the distance between a car they are parking and surrounding obstacles. They would also find it difficult to read maps and even to see things in a global fashion, such as seeing ears, eyes, and a nose, and identifying the object as a face. Seeing things in a global fashion is something that happens automatically. It's not a conscious process. If you look outside at your car, you see individual components like the tires, doors, hood, etc. Your brain groups these things together into a single object that we define as a car. The area of the brain primarily associated with visuospatial abilities is the parietal lobes. Next is the category of sensation and perception, which includes basic vision, auditory, and tactile functions. Deficits in sensation and perception can drastically affect a person's everyday life. If you had a deficit in visual depth perception, you could misperceive stair steps and fall. If you had an auditory deficit, you might misperceive what someone is saying to you. And if you had a tactile deficit, you might have a decreased sensitivity to touch. By assessing these deficits using neuropsychological tests, we can figure out how best to help affected individuals live independently for as long as possible. Turning to the motor skills category, this includes a wide variety of abilities such as hand-eye coordination, walking, balance, finger dexterity, and motor speed. Individuals with these types of deficits may have trouble catching a ball, or they may easily fall because of poor balance. Problems with particular types of movement can be indicative of certain types of pathology. Moreover, problems with motor speed can influence performance on neuropsychological assessments if they involve fine motor movements. Finally, we have the category of mood and orientation. Mood has to do with a person's emotional state. For most of the disorders we will be discussing, measuring levels of anxiety and depression is an important part of treatment, as these are the most common mood symptoms associated with a variety of brain disorders. Orientation is a person's basic awareness of themselves in relation to the world around them. In neuropsychology, orientation refers to an individual's knowledge of who they are, so orientation to person, what the date is, orientation to time, and where they are located, orientation to place. Various mental status examinations help to establish orientation. Deficits in orientation are typically seen in individuals with dementia. To recap, the categories of functioning that experimental and clinical neuropsychologists assess are memory, attention, language, executive function, visuospatial abilities, sensation and perception, motor skills, and mood and orientation. Experimental neuropsychologists use these categories to help identify the pattern of deficits associated with particular brain disorders by analyzing research studies involving different patient groups. Clinical neuropsychologists, meanwhile, use the scientific information to help them assess and diagnose individuals suspected of having a brain disorder. By understanding the types of functional deficits an individual with a known brain pathology has, we can do two important things. First, we can better understand how different brain areas relate to particular functions in the normal human brain. And second, we can better understand the functional strengths and limitations associated with different disorders. The resulting neuropsychological profile, so to speak, will not only help in the diagnosis of different disorders, but also provide us with information about how people with different disorders will be able to function in the real world. So as you can see, a neuropsychological assessment can offer us a wealth of information about people with brain disorders. And the assessment process itself is quite comprehensive. The first thing a clinical neuropsychologist does during a visit is conduct a very thorough, detailed interview, typically with the patient and their caregivers. This interview usually takes 45 minutes to an hour to complete. Topics generally covered include the following: the patient's medical and psychiatric history, a list of current medications, the types, examples, onset, and course of any symptoms the person has, any developmental issues, such as problems during birth or any serious illnesses or injuries they've had, sense of academic achievement, such as whether they have had any learning disabilities or attended college, levels of present functioning, such as whether they can normally perform daily activities like dressing themselves, feeding themselves, and so on, family history, including both physical and mental health, quality and quantity of sleep, mood changes, alcohol and drug use, changes in appetite, and much more. As you can see, it is a very comprehensive interview. Following this interview, a battery of tests is conducted. These tests generally take 1 to 3 hours to complete. The testing battery is flexible and can change depending on what the neuropsychologist finds. These tests assess the various categories of functional abilities we've discussed here: memory, language, attention and executive function, visuospatial abilities, sensation and perception, motor skills, and mood and orientation. Neuropsychologists using what is called the Boston process approach will not only be interested in the participant's score on these tests, but also in observing and noting how they complete each assessment. In other words, whether the person makes any errors, and if so, what kind, whether they get distracted, how long it takes them to complete the assessment, and so on. This information is extremely useful in understanding a person's cognitive and behavioral deficits. Here's an example. One simple way to test visuospatial abilities is to ask patients to draw a clock and set the time to 10 after 11. Neuropsychologists want to know how accurately the patient can draw the clock, where they place the numbers, and whether they're in the proper order, and their ability or inability to set the time correctly. Different types of errors indicate different types of visuospatial impairments. Or consider tests to determine attention and executive function abilities. For these, neuropsychologists want to know whether the patient can sustain attention for a period of time and whether they can plan, organize, and problem solve. To assess attention, they might ask the participants to connect a series of dots numbered from 1 to 25 in consecutive order. Then, to test executive function, they may ask the patient to consecutively switch between numbers and letters. For example, 1A, 2B, 3C, and so on, with the goal being to connect the dots as quickly as possible. They may also ask patients to repeat back a string of digits, adding progressively more digits until the patient starts making errors, as a way of testing attention, and ask them to repeat these strings in reverse order as a test of executive function. These two connect the dot assessments, one for attention and one for executive function, are actually parts A and B of what's known as the trail-making test. How a patient performs on these various assessments and the types of errors they make will not only help the neuropsychologist figure out what type of brain disorder they have, but will also give the patient's family a sense of what the patient can and cannot do in everyday life. So things like driving, managing their own finances, and living independently. In addition to administering tests, the neuropsychologist may also have the patient's caregiver complete a questionnaire that examines general functional abilities. This provides an even better idea of how well the patient can perform day-to-day activities. The neuropsychologist will next write a report on the patient's background, test results, diagnosis, and recommendations, putting together a holistic picture of what's going on. This report will be sent to the patient's primary care physician. The neuropsychologist will also then meet in person with the patient and their family to explain the findings. As you can see, a neuropsychologist is a very valuable member of the team when trying to provide the best care possible for someone who has a brain disorder. For the remainder of this course, each lecture will cover the neuropsychological impact of a specific common brain disorder. Thankfully, a great deal of research exists for each disorder we will examine. For each disorder, we'll explore the underlying brain pathology as well as causes and treatments, but also, and perhaps most important, how these disorders affect a person, their personality, memory, decision-making skills, mood, and so on. Learning how to recognize symptoms and help people suffering from one of these disorders is crucial to helping them lead an independent lifestyle for as long as possible. As you go through the lectures, you will also quickly see that both genetics and environmental factors play critical roles in the development of these disorders, and that in some cases, some of those environmental factors are under your control. The best possible thing you can do to minimize your risks of developing a brain disorder is to live a healthy lifestyle, including making healthy food choices, getting regular exercise, avoiding tobacco, and keeping medical issues such as high blood pressure, high cholesterol, and diabetes under control. 7 years ago, I was 55 pounds heavier, had high blood pressure, rarely exercised, and worked all the time. Stroke runs in my family, and I knew I had to make some lifestyle changes if I wanted to avoid having one. I've always enjoyed biking, so I picked that up again. And then I learned how to run using the Couch to 5K app, and then I learned how to swim. Do you know how hard it is to learn how to swim in your late 40s? Very. Next thing you know, I was running a 5K and a sprint triathlon. Later, I joined a triathlon team where I met a variety of great athletes and friends. I ended up running the Boston Marathon and doing half Ironman races. Taking those first initial steps changed my life. I'm a much healthier, happier version of myself today than I was 7 years ago. And I know I'm doing what I can to reduce my risks of getting many of the brain disorders discussed in this course. There's no guarantee I won't get any of them, but I know I'm doing everything in my control not to. Thank you for joining me today. In the next lecture, we'll start our in-depth exploration of brain disorders by discussing intellectual disabilities and Down syndrome. See you then.